Good morning, good afternoon, good evening, depending on whichever part of the world you are in. I'm Dr. Ravindra Verma on behalf of NNF Kerala and NNF IAP Neocon. Welcome to this another edition of Learn from the Legends. We have a great session ahead of us. Joining us from USA is Professor Seetha Shankaran, who needs, I think, no introduction to the neonatology people all over the world. She has done the pioneering research in therapeutic hypothermia, and which has become now a standard of care as far as neonatology hypoxic ischemic encephalopathy is concerned. She will be talking on recent advances and controversies in therapeutic hypothermia. And to moderate this session, we have two legends in the field of neonatology. Dr. Professor Siddharth Ramji from Delhi, who is well known for his research on neonatal resuscitation without oxygen, and Dr. Manikot from Muscat. Both of them are legends in their own fields. And we have joining us from all over the world number of delegates. Already we have crossed 150 delegates, and many more will be joining in YouTube. And you are the people who has made this a great success, the Learning from the Legends series. So once again, welcoming you all, I hand over the mic to Dr. Professor Siddharth Ramji as well as Dr. Manikot. Professor Ramji, madam, sir.
Thank you, Dr. Verma. Friends, I think the topic that is for discussion today is very important. Therapeutic hypothermia, as you know, has considerably changed the outlook for babies who have suffered severe asphyxia and encephalopathy. But it has not been without its share of concerns and controversies. And there have been concerns, especially about its applicability when you shift to low and middle income countries. And I think we have the most appropriate person today, Professor Shankaran, with a huge, vast, many years of experience, and having had also participated in studies which have gone beyond the American continent and involved in low and middle income countries. I think she has a great perspective which she will offer us today. So I am not going to say much more except to say that I want all of you to listen carefully to what she says, but at the same time feel free to pen down into the chat box all the questions, queries that you may have, and I'm sure that she'll be more than happy to answer all of them. I now hand it over to Dr. Prakash to introduce our speaker for this evening. Dr. Prakash.
Thank you, Professor Siddharth. A warm welcome to all of you. It's a great honor and privilege for me to introduce the esteemed Professor Seetha Shankaran, a living legend who devoted her entire career in improving the lives of high-risk newborns. Dr. Shankaran joined Wayne State University School of Medicine, Children's Hospital of Michigan, and Hartzell Women's Hospital in 1975. She served as the chief of the Division of Neonatal Perinatal Medicine and director of the regional neonatal programs for the Detroit Medical Center from 1990 to 2016. Dr. Shankaran has performed multi-center randomized controlled trials and longitudinal prospective studies of high-risk infants from childhood to adolescence with a focus on etiology, risk factors, management, and prevention of brain injury. She was the principal investigator at the Wayne State University's site of the NICHD Neonatal Research Network and the PI of the first RCT examining whole body hypothermia as neuroprotection for neonatal hypoxic ischemic encephalopathy. The trial results were published in 2005 in New England Journal of Medicine. This therapy of cooling for 72 hours at 33.5 degrees centigrade has become the standard of care throughout the world. She also evaluated the 6 to 7 year outcome of trial participants and published in NEJM in 2012. Dr. Shankaran has described the MRI pattern of brain injury that correlates with outcome. Her most recent contribution was performing the RCT, evaluating optimizing cooling strategies for moderate or severe HIE. The results noted increased mortality with longer or deeper cooling, and it was published in JAMA in 2014. The primary outcome of the study demonstrating lack of efficacy of either longer or deeper cooling at 18 months of age was published in JAMA in 2017. Dr. Shankaran is currently examining the neuroimaging status of trial participants. A picture is worth 1,000 words, and a photograph of one of the infants who underwent whole body cooling, and Dr. Shankaran is on the NICHD Director's Hallway as the most significant contribution of NICHD neonatal network in the past 25 years. A PubMed search for Shankaran S lists 432 publications, and the Microsoft academic list 36,381 citations in top medical journals. Dear friends and colleagues, cooling for HIE is no longer a cool decision to take due to the complex and dynamic nature of perinatal asphyxia and the difficulty in differentiating mild from moderate HIE. Dear Professor Seetha Shankaran, we are eager to listen to your words of wisdom, and the virtual space is all yours for the next 1 hour. Let me remind the participants to enter the questions in the Q&A box and not the chat box. Over to Professor Seetha Shankaran.
Thank you. So I just wanted to say that I learned some new things from you, Prakash, just now that I didn't know, but also that I am from Kerala. My family is from Kerala, and I grew up in the Nilgiris, near Ooty, in a town called Wellington. So I am very attached to both Kerala and to Madras State. So I'm going to share the screen. Just continue, right?
Please.
Okay. All right, thank you. Okay, now how do I advance the slides?
Right arrow.
The right arrow. No.
Or down arrow, whichever.
I've tried all. Wait,
So,
maybe I can.
just click on the slide. Then it will
And double click on the screen on the slide that you're projecting.
Okay.
Yeah.
Okay, I could do that.
Now you can use the up and down arrow.
Okay. All right. Okay. Okay. So, let me just 1 second. I can minimize this. All right. So what I want to do first is just briefly go through what has already been mentioned, which is the rate of death or disability at 18 to 24 months of age following cooling for 33.5 degrees Celsius for 72 hours. And as you can see in this slide, which has listed all the major trials, you can see that in the NICHD trial, in the European trial, the trial from China, and the ICE trial, there was a significant decrease in death or moderate or severe disability at 18 to 24 months of age in the hypothermia group as compared to the control group. So this was the primary outcome of all the trials. And if you look at the secondary outcome of hypothermia, then you see that the rate of cerebral palsy, which was one of the secondary outcomes, was also significantly decreased in the TOBI trial, the European trial, and the trial conducted in China, with a lower rate in the hypothermia group compared to the control group. So what I just want to also bring to your attention is that we compared the rate of death or disability in the cool group from the first trial that I just showed you, and compared that rate with the usual care cooling in the optimizing cooling strategies trial, where we had randomized infants into 4 different depth and duration of cooling. So when you compare the same depth and duration between 2005 and 2017, you can see that the rate of death or disability has been decreased from 44% to 29%, and the mortality has gone down from 24% to 9%. So this is probably due to changes in care that have also been optimized in the care of these infants. There's been a slight increase in the number of infants with a normal cognitive outcome, as well as an increase in the number of infants with a motor outcome. Interestingly enough, at least from our data, the rate of cerebral palsy has remained unchanged, 19%. So one of the updates is, what is the outcome in childhood following hypothermia? Does this neuroprotection persist? And the first publication about outcome was from the CoolCap trial, where they presented the 6 to 7 year outcome. And the way the infants were evaluated was with a questionnaire to the parents assessing disability. And only 46% of the surviving children participated in this project. And what they found was that the disability status at 18 months was strongly associated with the disability based on this questionnaire called the VFAM. And here I present the NICHD results looking at 6 to 7 year outcomes. The primary outcome here, since the children are older and we can evaluate them with IQ, was death or an IQ of less than 70. And you can see we had, around the same percentage of improvement, 47% in the hypothermia compared to 62% in the control group. When you look at these figures, it is statistically significant. This is unadjusted risk ratio, but when you adjust for level of encephalopathy and for center, then you lose the statistical significance. But what this does show is that the neuroprotection that was seen at 18 months continues at 6 to 7 years of age in infants in the high income countries. Secondary outcomes, we looked at, we were able to look at fine and detailed outcomes in the children. So among the children who did not have disabilities, we were able to evaluate attention and executive function and visuospatial activity. And here you see the results of the children who scored very low on it. There's a slightly lower incidence in the hypothermia versus control, but the numbers are relatively small and not significant. And we also looked at very fine motor function. We looked at everyday motor, complex motor, fine motor between the two groups, and we didn't find any difference between the two groups of infants. And these are only looking at non-disabled infants. So we have taken out all the infants who have cerebral palsy. The TOBY trial also presented data at 6 to 7 years of age, and the outcome here is survivors with an IQ equal to or greater than 85. And here you see that there is a significant increase in the number of children, 52% versus a control of 39%, who survived with a normal IQ at 6 to 7 years of age. So clearly what this shows is that the protective effects of hypothermia in moderate or severe HIE in the high income countries were continued up to childhood. You have to see that most of the pediatric and adult studies of hypothermia have just 6-month outcome or 12-month outcome after the intervention. So that's why this data is so important. The secondary outcomes in the TOBY trial, here you see cerebral palsy. There is a lower incidence of CP, 21% versus the control of 36%. Although we have to remember that there was no data for a fair number of children 18 hypothermia and 27 control group infants. So this was alluded to earlier. Can greater neuroprotection be achieved with longer cooling or deeper cooling, or a combination of both? And this has been justified to do the study because when you do MR thermometry, the basal ganglia thalamic temperature is higher in infants who have severe HIE compared to those who have moderate HIE. So the trial that was planned in the network was to enroll 726 infants and test 4 different temperatures that I've shown in the slides: 33.5 for 72 hours, 32 for 72 hours, 33.5 for 120 hours, and 32 for 120 hours. But the trial was stopped when 364 children were enrolled, because the Data Safety Monitoring Board noted that the mortality, in-hospital mortality of the usual care group was only 7%, and it was double that in each of the longer and the cooler, deeper cool groups. And so the trial was stopped. Here you see the primary outcome, and this is the primary outcome comparing all infants cooled for 72 hours compared to those for 120 hours. And you can see there is a difference in mortality. So longer cooling was associated with a higher risk of death. So the next update is there an early biomarker that correlates well with later outcomes? And people are very interested in this because, you know, doing a follow-up study to a minimum of 18 to 24 months is quite expensive. Is there something that we could look at in the neonatal period that correlates with later outcomes? So this is data from the neonatal network study where we looked at the MRI, and we had MRI in 126 infants, 136 infants. And you can see here that when we looked at the number of infants with a normal MRI, there was a trend that there were more infants in the hypothermia group with a normal MRI. When we looked at the posterior and anterior PLIC and ALIC, again, there was a difference. And there was certainly a decreased number of areas of infarction in the hypothermia group as compared to the control group. And when we looked at the way we scored the injury on the MRI, which is a higher score is associated with more injury. For example, 3 is when the entire hemisphere shows brain injury. You can see that there was a very good correlation between the NICHD score and death or disability at 18 months of age, and disability among survivors at 18 months of age. And then among 96 children, which is a subset of the original, we were able to look at the relationship of the neonatal MRI and outcome at 6 to 7 years of age. And here again, you see that those who had a normal neonatal MRI in the neonatal period had much higher rates of no or mild disability, whereas those who had the worst MRI in the neonatal period had a higher rate of moderate or severe disability. So the neonatal MRI is a good marker of outcome, both in childhood and at 6 to 7 years of age. This is to show you, exactly what are the areas of the brain where there appears to be injury. And we looked at the areas of the brain and correlated this with the IQ of the children at 6 to 7 years of age. And you can see that the children with a low IQ less than 70, had met much higher frequency of injury in the cerebral area, in the basal ganglia and thalamus, and again in the posterior limb of the internal capsule, watershed areas, and hemispheric, whole hemispheric involvement. So this can give you a good idea when you're doing counseling of parents. And both the TOBY trial and the ICE trial also published data on neonatal MRI and 18 or 24 months of age. In the TOBY trial, 131 of the infants had an MRI, and there was a reduction in the hypothermia group in injury to the basal ganglia thalamus, the white matter, posterior limb of the internal capsule, and that the MRI was an excellent predictor of death or disability at 18 months of age. In the ICE trial, 128 of 221 infants had an MRI, and they also looked at diffusion-weighted imaging. And here you see that hypothermia reduced injury in the white matter, as well as cortical gray matter abnormalities. And the greatest predictive value for 2-year outcome was PLIC and BGT abnormalities. So all confirming that neonatal MRI is really a good predictor of outcome. And the MRI is, of course, widely available in most centers. But is there any other marker? Now, this is data from the MARBLE study, which was conducted by Imperial College London, had multiple sites, and we were fortunate enough to participate. And the PI of this study was Sudhin Thayal, who organized it. And Peter Lally was the first author of this publication. So here you see, this was published in 2019. Here you can see that when you look at the concentration of NAA, or if you look at the NAA by choline ratio or the NAA by creatine ratio, you can see that you can clearly separate out the infants with a normal outcome at 18 months compared with an adverse outcome looking at each of these different parameters. So it appears that, doing spectroscopy in the neonatal period is also an excellent biomarker. The investigators correlated the Bailey score with the absolute NAA quantification. And you can see here, the infants who did poorly had much lower concentration, whether it was, this is the Bailey 3 cognitive score, the motor score, or the language score. So very good predictive ability of the spectroscopy and mild, moderate, or severe outcome of the infants. And the group actually looked at all the predictive variables. They looked at clinical assessment, AEG, MRI, diffusion MRI, and spectroscopy. And you can see, how well each of these areas, each of these parameters did as predictors of outcome. And it looks, as you can see here, that, the best one probably is the spectroscopy, actually even better than the MRI in predicting outcome. So I think this is very exciting data and needs to be confirmed by other investigators. But clearly, this is another tool that can be used early in the neonatal period that correlates well with outcome. So just a brief touch on what are the updates of hypothermia plus therapies. These are interventions that are added on top of hypothermia. So the status now is that we have data that is still pending on hypothermia plus EPO, hypothermia plus melatonin, and the umbilical cord blood studies. So this data is forthcoming and should be, very interesting when they are published. What we do know from prior trials is that xenon, magnesium sulfate, and topiramate have not been shown to be beneficial. And, even though in the preclinical model, they may have been beneficial. One thing that I will say is that future studies should be adequately powered, as hypothermia for HIE now is noted to have a decreasing mortality. I showed that to you earlier. And for the time being, the gold standard will still be neurodevelopmental outcome at 18 to 24 months of age. But I think there is, in all of these studies, the EPO, the melatonin, and the hypothermia in the low and middle income countries, spectroscopy is also being evaluated, and that should be very exciting data once it comes out. Now, what about the controversies in therapeutic hypothermia? One area that's being debated is the use of sedatives and analgesics during the cooling process. So preclinical data has shown that hypothermia was effective only in the sedated model. And we know that in both the pediatric cooling trials for traumatic injury and for cardiac arrest, and the adult trials for the same diagnoses, the patients have to be sedated because while they're being cooled, they shiver very, very severely and thus increase their own body temperature. Now, data from the neonatal network study that was published has demonstrated that there was no efficacy of sedation or analgesia as a protective agent. And there have been multiple publications that have shown that there is accumulation of morphine in infants with HIE. Parents are also very concerned when the children have morphine because they often correlate it with their adult relatives getting end-of-life care. And they are also concerned with morphine and addiction. So something to keep in mind. And also that if sedation is being used, that it should be used with caution during the period of use. What are the other controversies in therapeutic hypothermia? Now, I've also already shown you that it works, again, between 33 to 34 degrees Celsius for 72 hours, and it works in the greater than 36-week gestational age infant. And the inclusion criteria for each of the published trials was infants at highest risk, so severe acidosis or need for resuscitation, and only those who had moderate or severe HIE. And in all the trials, cooling was initiated within 6 hours of birth. What we find now is that there's quite a bit of therapeutic drift in the use of hypothermia. Now, hypothermia is being used for other diagnoses, such as cardiorespiratory arrest or apnea. It's being offered to infants who are less than 36 weeks gestation. It's been offered extensively to infants who have mild HIE, and it is being used in the low and middle income countries. So let me address each of these topics. Let's talk about infants who are less than 36 weeks gestation. The American Academy of Pediatric Guidelines included use of hypothermia for HIE among infants who are 35 weeks gestation. That was the statement that originally came out, even though most of the trials used infants who are 36 and beyond. However, we know now from the registry, the TOBY registry from the UK, that many infants who are less than 36 weeks gestation are being cooled. We don't know how they do because there's no outcome data. The Vermont-Oxford Network Registry also reports cooling of infants who are less than 36 weeks without any outcomes. And 2 of the randomized controlled trials for HIE, when they were published, stated that they had inadvertently enrolled 35-week gestation infants, but they never really reported on the outcome of those infants. There is a fairly recent report of cooling of infants with preterm HIE. It's from a single center. It's 30 infants, 33 to 35 week gestation age. The primary outcome was very similar to all the trials. When you look at in-hospital complications, coagulopathy, seizures, hypotension, persistent acidosis, and thrombocytopenia was noted. And when outcome was evaluated, there were 4 deaths, 18 survivors were followed. So that means only 67% were followed. So that's, that's not a good rate of follow-up. Primary outcome of death or disability was seen in 50% of the known survivors. And 8 of the infants were completely lost to follow-up. So their status is not known. So this really does not answer questions whether hypothermia is protective for preterm HIE. However, there is an ongoing trial. This is being conducted in the NICHD Neonatal Research Network, looking at 33 to 35 week gestation age infants. The PI is Roger Fakes. We are looking at safety outcomes, hemorrhage, thrombosis, bleeding, acidosis, arrhythmia, neck, and death. And the primary outcome is death or moderate severe disability at 18 to 22 months corrected age. And the sample size is 168 infants with analysis done using the Bayesian analysis. All the infants have been enrolled already, and follow-up is sort of halfway through. So we should have data in a couple of years. Let's move to the other conditions. This is a report from the UK in 2014, where 36 infants were cooled for other diagnoses. Those who came in beyond 6 hours of age, those who had postnatal collapse or cardiorespiratory arrest, major brain hemorrhage, congenital cardiac disease, and surgical conditions. So it should be noted that among all these conditions listed here, there is evidence-based data only for cooling of infants beyond 6 hours of age. This was published in 2017 and was a network trial and showed that among term infants, cooling may be safe or effective. So if you look here at the data from the study, you can see in the frequentist analysis, death or disability was the same, 24%, 27%. But then when you do the Bayesian analysis, that there is a probability of benefit of about 76%. So what I would suggest is if you do have a baby who arrives to your neonatal unit beyond 6 hours of age, and I'm talking about the high income countries, what we are doing is that we discuss it with the parents and get informed consent and then offer cooling if the infant arrives between 6 and 24 hours of age. The other interesting thing in this study was that when the Bailey scores were evaluated, when you look at the scores between the cooled and the non-cooled, the cooled infants had slightly higher cognitive scores. Now let's move to a topic that's of tremendous interest now, and that is hypothermia for HIE in the low and middle income countries, because there have been multiple reports that this therapy is being applied without safety and efficacy data. So the results of the trial that was done in LMIC was presented at the PAS meeting by Sudhin, and many of you know him, and we have worked together. So I have borrowed a couple of slides from him. So this was the protocol that was developed, and the protocol was actually published for everyone to see in 2017. And the idea was to see if therapeutic hypothermia initiated within 6 hours of birth, continued for 72 hours using a servo-controlled cooling device, along with optimum supportive neonatal intensive care, would reduce death or disability when compared with usual intensive care alone in term babies. And this is only moderate or severe HIE infants outcome is 18 to 22 months, and the trial would be tertiary neonatal infants in South Asia. So this was conducted in Sri Lanka, Bangladesh, and multiple centers in South Asia, and many of you have participated. The primary outcome was very similar to the prior trials, of course, using the Bailey 3. So the moderate disability was Bailey 3 cognitive score of 70 to 84, and the GMFCS classification level 2, hearing impairment with no amplification or a persistent seizure disorder at the time of the follow-up visit. Whereas severe disability was a very low Bailey score, less than 70 in the composite cognitive score, GMFCS level of 3 to 5, which sort of correlates with moderate severe CP, profound hearing impairment requiring either hearing aids or cochlear implant or blindness. I think the great advantage of this study was that all infants had the 3T MR spectroscopy and NAA levels measured. And the secondary outcomes that were looked at was mortality, severe disability, and microcephaly at 18 months. Inclusion criteria was need for continued resuscitation at 5 minutes of age, and or a 5-minute APGAR score of less than 6, and moderate or severe encephalopathy on the modified SANAT scoring. An exclusion criteria was absent heart rate at 10 minutes despite adequate resuscitation, life-threatening congenital malformations, and inability to attend follow-up assessment. So it's different from the trials in the high-income countries, but very suitable for the LMIC. And the sample size was to look at a 30% risk reduction. So you would need 204 infants per arm, which is a total of 408. So here is the data. So this is the data at hospital discharge. As you can see, 202 hypothermia infants, 206 usual care infants. What you see here is that among the cooled infants, there was a higher rate of gastric hemorrhage. There was a significantly higher rate of hypotension, pulmonary hemorrhage, prolonged blood coagulation, severe thrombocytopenia, and a higher mortality rate, 36% compared to 24% in the usual care group. So these are the hospital outcome data. At follow-up at 18 to 22 months, and there was a very high follow-up rate in this trial, you can see that death or moderate or severe disability occurred in 50% of the infants and in 47% with usual care, so no difference. If you look at mortality, total mortality, until 18 months of age, the mortality rate was higher in the infants in the cool group compared to the infants in the usual care group. All other secondary outcomes were not different between the two groups. Microcephaly was, interestingly high in both groups. So there was no difference in survival without neurodisability, no difference in seizures, blindness, or hearing. So what this trial shows is that hypothermia for moderate or severe HIE in low and middle income countries is not safe and not effective. And then I want to move on to another area where there has been therapeutic creep without any data, and that is mild HIE infants. Now, follow-up studies of the mild HIE infants, when you review them, they're hard to evaluate because definitions are inconsistent. Diagnosis was made over many days, but the bottom line is that meta-analysis of the studies estimates that 25% of these infants are at risk for deficit. So that's quite high, 25%. Now, what is happening with these infants? So there's been evidence from survey data that physicians are very keen or already provide hypothermia for mild HIE. You can see the data from the UK. You can see in registry data, both in Vaughan, the Toby, and the French registry, that over 1,000 mild HIE infants have been cooled. Now, this is definitely an underestimate because this is only the published data. Of course, from all this information, there's been no outcome data from these various cooled infants to tell us how these children do. If you look at the MRI, there is evidence of brain injury, but it's very variable. The rates are all over the place, 11% to 40%, depending on whether it was retrospective study, prospective study, cooled infants or not cooled infants. There does appear to be injury when it is noted in the watershed areas rather than in the basal ganglia. In one trial where mild HIE infants were inadvertently enrolled as part of a multi-center study of moderate or severe HIE infants. So there are 37 infants here. 11% had brain injury because they all got MRIs, and this was injury in the white matter of the brain. So the deep gray nuclei were not involved. The MRS was done on all these infants, and the MRS was normal for all of the infants. And when they were evaluated, 30 out of the 31 who were evaluated, so 6 were lost to follow-up, at 2 years of age, they were normal. So this data, appears to show that it's not as bad as 25% from the previous meta-analysis. This is data from the PRIME study, a prospective study that we participated in, where infants were enrolled as part of a multi-center study. There were 63 infants who were enrolled, and the inclusion criteria were exactly as that of the trials in the high-income countries. The definition of mild HI was any abnormality on the SANAT score less than 6 hours of age. Disability, again, was by the NICHD trial criteria. Now, on follow-up, 81% of the infants were evaluated. So, looking at follow-up studies, 81% is a low rate. And only 68% of the infants had a Bailey score. So we need to keep that in mind. In spite of that, the outcome showed that 16% of the infants had a disability at 18 to 22 months of age. So in 2018, there were 2 meta-analyses that were published that were fairly detailed, looking at mild HIE among those infants who were included in randomized controlled trials. In the first meta-analysis, which included 91 infants with 45 cooled and 46 not cooled, the adverse outcome rate in the cooled infants was 29%, and in the 37 in the non-cooled. In the second meta-analysis, that included more infants because the authors had got in touch with all the PIs of the trials and got numbers from them on how their mild HIE infants did. You can see here that the adverse outcome now is 19.6%, with 19.6 that are not cooled. So, what is the rate of poor outcome after mild HIE infants? It's probably, lower than 25%, maybe around between 16 and 20%. So what the authors have stated in their paper, that this meta-analysis proved that evidence was insufficient to recommend cooling for mild HIE, and that significant harm or significant benefit could not be excluded based on what has been shown so far. So recently there's been, questions brought up. What is the preclinical data? Should hypothermia be offered to infants with mild HIE? Well, in the mouse model, hypothermia actually decreases white matter injury. And the mildly injured brain, as compared to the brain that has complete injury, the mildly injured brain had greater neuroprotection. And the other thing that was noted in these studies was that cooling for 48 hours was less protective than longer duration. So are we ready for a randomized controlled trial of hypothermia for mild HIE? So my colleagues and I had, written an opinion piece last year where we said that anywhere from 20 to 36% of infants with encephalopathy have mild HIE. And so to evaluate the outcome of these infants, we need to design the trial with inclusion criteria for infants at highest risk. So only those with acidosis and resuscitation. And then, very important, there should be defined criteria for the neurologic exam for mild HIE. The current depth and the current duration of cooling should be used, which is 33.5 or 72 hours, because that's the only, safe, what has been shown to be safe so far. And then outcomes should be evaluated, not at 18 or 24 months, but probably at 5 years of age, because we can see that, the brain injuries in the watershed areas of the brain, these infants may have cognitive and behavioral abnormalities rather than, major motor abnormalities. So they need to be evaluated at an older age group with very robust measures. And then we can say that if cooling is safe and effective, yes, let's offer cooling. If cooling is not safe and effective, then it should be discontinued. So these are the conclusions that I have come to, looking at updates of hypothermia. Usual care is safe and efficacious in the high-income countries. The early biomarker of outcome in infancy and childhood is an MRI, and MRS is very promising. Sedation and analgesics should be used with caution, and that neither safety nor efficacy of cooling for moderate severe HIE has been shown in the low and middle income countries. The practice should be discontinued based on the trial that was recently presented and will be published fairly soon. Under the conclusions from the controversies, in the following conditions, safety and efficacy has not been demonstrated: postnatal collapse, severe surgical conditions, infants who are less than 36 weeks gestation, and infants with mild HIE. So we should probably, wait the results of ongoing trials or conduct trials that will give us answers to these questions. Thank you.
Thank you so much, Dr. Seetha. I think that was a very, very exhaustive but very clear update on the current status. There are a huge number of questions in the question answer. You have already addressed several of them.
Okay.
But I think one of the concerns that a lot of people have raised is regarding why is it that LMICs fail? Because we still have the highest burden of babies with HIE in this country.
Exactly.
And the challenge of even offering good, post-survival rehabilitation care is another challenge in this country. So
Yes.
net effect is that even among survivors, we often are challenged with our inabilities to provide optimal care. So outcomes are not what they should be as they are in the high income countries.
Right.
Of course, our babies also experience very adverse intrauterine environments in the antenatal period. So, what do you think is? Do you believe there could be a subset of babies on whom people could try? Are there settings where people could try? What are the cautions if somebody was to implement therapeutic hypothermia in our countries?
Yeah, I mean, that was one of the questions from the reviewers, and I'm not a big fan of subset analysis, but I'm not sure. I don't think until we have more data that we will have enough information to say, which subset of infants will benefit from cooling. I think a good thing to do is to really look at non-cooling interventions that can be applied to LMICs, and that is being planned. For example, if the HEAL trial, which is the ongoing hypothermia plus EPO trial, that may give us some information. But I think doing a trial on EPO or darbepoetin, those might be approaches that are the way to go rather than to use cooling, because not just the efficacy, the safety data also from the trial that was just presented at PAS is of great concern.
Right. So clearly at this moment, the evidence is so there seems to be something very different, even if you practice newborn care well, but
Right.
there is something else about our subset of kids which
Yes.
doesn't seem to help them as it has done in high income. And I think that's a very
Exactly.
important
Yes.
message. We should, all of us in this country, need to be cautious about.
Right. Yes.
The,
There was
the,
an earlier onset of seizures in the infants in the Helix trial. And as I mentioned, the number of infants with a small head size at birth was also much higher than in the HIC, high income countries. So the infants are different. Yeah, the infants are different. And it is true, the intrauterine milieu is probably more challenging, definitely more challenging in the LMICs with undernutrition, higher maternal disease burden, infection, etc. Yeah.
so there are a large number of questions. So I'm going to ask Prakash to run through those questions with you. I'm sure some of them are actually overlap, so I think Prakash can summarize them and you can answer them all together. So Prakash,
Yeah,
over to you.
yeah. Let me just pick up a few among the load of questions. Let me start with a practical question. Immediately after resuscitation, many babies with mild HAE will resemble moderate HAE.
Yes.
What are your comments about the practice of passive cooling soon after resuscitation based on the delivery room diagnosis of birth asphyxia? Is it better to give adequate post-resuscitation care for an hour, avoiding hypothermia, followed by controlled cooling if necessary?
No, I will definitely go along with the second suggestion, which is focus on the resuscitation, because infants who are born after a very, strenuous birth process can be extremely floppy. Those who are severely anemic can be extremely floppy. So one really has to resuscitate the infants, wait for the resuscitation efforts to really kick in, and then evaluate the infant. So I would not advocate turning off the warmer in the delivery room and cooling the infants passively. I'm sure other senior investigators don't agree with me, but I do not think that is the way to go. That's actually one of the reasons why in the HEAL trial, they made it very clear that the first neuro exam should be done only after 1 hour of birth, which gives the infant a chance to recover. Then you do your neuro exam.
Okay, ma'am. Thank you. Anand Peters wants to know, whether the IQ studies in the different reported trials were corrected for mid-parental IQ.
We did, in our trial, we didn't correct it for parental IQ, but we did have a subset of parents also who had an IQ based on an interview process. So we did not correct for parental IQ, no.
Okay. Plenty of questions related to the Heliox trial. What do you think is the reason for the failure of the Heliox trial? Were there differences in outcomes between the centers in the particular study, or all the centers had the same uniform bad outcome?
I believe Sudhin did look at the outcomes in the centers, and there was not a difference, I believe, but don't quote me on this.
Yeah, your figures.
Yeah, I know that extensive, secondary analyses were done based on the reviews that were reviewers' questions. So no matter how you looked at it, there was really no benefit of cooling for these infants.
So what are the lessons to learn from this? Because physiology of resuscitation, asphyxia, pathophysiology are similar among the infants throughout the world. So there must be some factors which can be corrected.
Right.
What are the thoughts on that?
Well, I think the conduct of the resuscitation is fine. I'm not questioning that. I'm just saying that the infants who are born in the low and middle income countries, they are different from those who are born in the high income countries. And to be honest with you, even between the high income countries, there are differences. I can tell you that infants in the US, when you look at the follow-up, they're not as good as the Scandinavian and the Australian countries either. And that's because of the social determinants in this country, in the United States. So, all babies are not the same. And definitely the babies born in the LMIC, they are smaller in size. We had more infants who were less than the 10th percentile for weight and for head circumference. So that's why the babies are different. The maternal complication rates are higher. Yeah.
There is an interesting question about temperature. You have noticed that both deeper and longer cooling in treatment groups, as well as increased temperature in non-cool groups, have been associated with poor outcomes.
Right.
That is, the control group was having higher temperature right from NICHD. What is your opinion about a milder form of hypothermia, say 35 to 36, which may balance the benefits versus the risks of cooling? In the same category, Dr. Kishore Sangvi wants to know, how did you arrive at the magical figure of 33 to 34 and 72 hours?
Yeah, to be really honest with you, it was really based on the animal data. We looked at the preclinical data and saw that that cooling for 72 hours was done in the seizure. When you have seizures beyond that, seizures beyond the 6-hour window, then the infants, onset of seizures in the preclinical model beyond 6 hours was not protective. So that's how the 6-hour window was arrived at. And then the duration of cooling was based on how long was cooling beneficial in different animal models. So that's how we came to the 6-hour window to start cooling and the duration of 72 hours. Then the depth of cooling was also based on the preclinical data, because if you cool deeper than 32 and 30, then you start seeing the deleterious effects. So in the preclinical model, just dropping the temperature to 34, 35 was not as beneficial. The other thing I will say is that the first pilot that was done, and this was done by Alistair Gunn's group, Tanya Gunn, his mother actually did the study. She cooled the first 6 babies at 36, the next 6 at 35.5, the next 6 at 35. She went down by six babies in each of the temperature groups, and showed that this was the 33 to 34 was the ones that actually they tolerated it and they seemed to be doing better. Although it was a pilot study with only 6 babies in each group, and that was published. So when we designed our study, we decided, okay, let's take 33 to 34 degrees Celsius. And then we also decided to measure esophageal temperature, because we did a few animal studies and showed that the esophageal temperature reflects the deep brain temperature. So there's a lot of preclinical work in the 1970s and 1980s done on animal models of hypoxia ischemia. Very elegant work. So it was really based on those studies.
Okay, thank you so much. Thank you so much. Regarding mild hypothermia, most neonates with mild hypothermia have got excellent neurodevelopmental outcomes. And as you correctly mentioned, there has been a recent creep towards its use in mild HIE.
Yes.
However, recent studies also suggest adverse outcomes even for mild HIE based on MRI data. So how do you look at these opposing views?
So I really think that, in some infants with mild HIE will have or do have behavioral and cognitive dysfunction. And so what I think we really need to do is to do a good randomized controlled trial and see whether it is working in these infants, instead of just cooling them, which is being done all over the world in the high income countries, and then not doing follow-up. So I really think a good, well-powered, randomized controlled trial with very clear criteria of definition of mild HIE and very clear definitions of outcome in childhood, that should be done. I've been saying this for a while.
Okay. Thank you, madam. Can I pass it on to Professor Siddharth Ramji?
So, Seetha, the question is that then, what happens to all our traditional, asphyxia markers that you do in cord blood, etc., etc.? Are they really of any value in the way we look at things now? Or is this something we should just put it aside?
That's a very good question. I think if we can, I think if you can do whatever is your favorite cord blood test, but also publish that data in the current setting, I think that would be very informative. I agree with you. Yes, I think it should be done, but it should be published with follow-up. And follow-up at least to 18 months. I'm not saying try to follow up. At least 18 months. I think that would be helpful.
There is one question that people have posed, that is the difference in low IC countries a function of the center or the baby? Do you think that a child who comes to a better equipped center is likely to a better result, or irrespective of where you are, your level of asphyxia will behave the same way? And that's a question that many have questioned, whether we have provided suboptimal care.
Right. And the centers were selected because they had all the facilities. That's why they were selected to participate. I mean, and they had to have the appropriate, physicians and nursing care, postgraduates who were helping out. I mean, they did a great job taking all these babies for the MRIs. And a very committed follow-up team, unbelievable follow-up team that went, followed the children, and the developmental testers, during the COVID would examine the children on the terrace of the house because you're outside and do the baby, there. So yes, these are highly selected centers. And going back and looking at, were they all documenting APCA scores? Yes, they were. So I would say that these were, highly selected. And the argument is that if in these highly selected centers among LMIC, if it didn't work, then, those centers that are not that well equipped, it would be less safe there. I think that is the issue. Yeah.
Yeah, in fact, I think one of the very important things was as compared to many RCTs in countries like ours, this had very, very high follow-up rates. I know that we tracked every kid very carefully, even when they changed locations to ensure their assessments were done within the window period required for assessments. And as you rightly said, the enrollment itself was tight. They had to meet. So eventually, I think the message that I think everybody should understand is that even if care is good, and if you are in a certain part of the world, uh, the babies are different. Uh, so one has to be very cautious about whether this can become standard of care. So theoretically, today it is still investigative. You still need to seek a consent saying you're, like a trial. And it's not something I can offer a standard of care as possibly what's happening in the US and other European countries. So I think that's a challenge that we always have. So I see that we are, Prakash, Nisha, many other questions because we're coming to the running time. Are there any other questions you think that we have missed which should be addressed?
Some people want to know whether about enteral feeding during hypothermia.
That is a very good question, and actually there's been data, recent data also showing that it is safe to feed during hypothermia, that you can provide feeding during hypothermia.
But perhaps only with EBM and minimal enteral formula.
Yes. But you can feed them. When we did our first trial, we had absolutely no feeding at all. But now it's been shown that there is data showing that you can feed during this period. Yes.
I happen to see, I don't know which country, somebody offering even kangaroo mother care during therapeutic hypothermia. What is your opinion?
So they hold the baby with the blanket?
Yeah, that's right. That's right.
Significant complications. And the complications are listed on that slide. And if you are providing cooling, it has to be a very steady temperature during the maintenance phase of cooling. The initial, you do have, very often you have an overshoot below 33.5, then it comes up to 33.5, and then it should stay absolutely steady until the rewarm phase. And there's been data showing that when you cool and then when you rapidly rewarm, that is deleterious to the brain. So that's why if you have fluctuations in the core temperature measurement, you are definitely at risk for producing more brain injury. I think that I'm glad you brought that up because that's a very important point. Rapidly warming the brain is deleterious. That's why, we rewarm at 0.5 degrees per hour. So that is a big danger of cooling when you start reheating. Cooling and reheating, that is absolutely deleterious.
So clearly, cooling is like a drug which needs very fine controls, and not infusing or administering the drug as per the specifications can have increased adverse outcomes. And I think this is a very, very important message that all people on this who are listening to today should understand, that it needs intense monitoring. You can't just leave a baby and walk away. Somebody has to be on the watch saying what's happening. And as you very rightly said, overshoots both below and upward both have adverse effects. And I think this is something that we must recognize, and that's a challenge. Therefore, using devices which can't really control temperature in that narrow range that we are wanting to, I think is not a desirable practice. My concern is that you may save a baby, but you may actually end up resulting in greater disability. And that is, I think, sometimes a bigger burden to the family than just losing the baby. But this is a lifelong, um, pressure on the family. And I think in countries like ours, it can cause severe social and economic disruptions when you have a severely disabled kid.
I completely agree. I completely agree.
So, Prakash, are there?
Yeah, I think we will require several hours to answer all the questions, but I think we need to stop now. Thank you so much, Professor Seetha Shankaran, for these amazing presentations, and also the participants from around the world for your continued enthusiasm to learn from the legends. May I finally request Professor Shankaran to conclude the session by giving an important take-home message.
Based on everything that we've talked about, I think that the take-home message really is that we need to look for the results of the Helix trial that hopefully will come out very quickly, read it very carefully, and halt cooling for moderate severe encephalopathy in LMICs. I think that's the message I would like to give everyone.
Thank you very much for your words of wisdom. Over to Dr. Manoj.
Well, as we always say, the sweet things need to come to an end at one place, and this was one of the best of the sessions we have had so far. Thanks to the faculty and the moderators. Professor Shankaran, Madam is an inspiration for all of us in so many ways, and I really thank her from the bottom of my heart for having agreed to be with us today and share her wisdom, more than knowledge, the wisdom of cooling with us. So thank you so much, Madam. We expect to hear more from you from the coming days as well. And we were also thank you. We were also fortunate to have two legends moderating today's session. Both of them need no introduction. Professor Siddharth Ramji, of course, sir is known in various. He's a multifaceted personality. He's president-elect of NNF Kerala. Next year, he's going to be the president of NNF India. So he's going to be the president of NNF next year. And then he is one of the few researchers who keep relentlessly pursuing the research, and then the evidence the results are there for us to see in all the works that he has published. And he's a committed social worker. He is now pursuing the COVID pandemic, attacking it with all the kind of vigor that we don't see in so many of the seniors. Thank you so much for joining us. I also thank the other moderator, Professor Prakash Manikot. He is almost like a mentor to me. Like he has been there with us since the beginning, and then he is again one of those who pursue the topics to the end. So we are so fortunate to have all three of you for today's session. And at the end, let me thank all of you respected delegates. We are fortunate to have delegates from now 67 countries, and then they watch this over the next 24 hours. The views are going to shoot up, and thanks to faculty and moderators like you, the numbers are going up. We are very, very grateful to all of you. And before we wind up, I would invite all of you for the next session in the series. That is going to be again a second part of the new concept, use of artificial intelligence in neonatology. We saw the basic concepts of use of normal data and all. Now, Professor Carolyn McGregor, the authority on artificial intelligence, the chair of research in the artificial intelligence in Canada, is going to take us to a next level, how the concepts are going to be utilized. So we have this session on 20th of May, Thursday, at same time, 7:30 p.m. Indian time. So I invite all of you for that session. Until then, thank you so much from all of us here. Thank you for joining us. We are really honored to have you all. Thank you so much.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you. Thank you.
Bye-bye.
Bye.